On to the next presentation by Christoph Nienaber, a pioneer in endovascular treatment in type B dissection.
Yeah, I mean, I'm impressed how far the endovascular treatment concept already reached towards the aortic valve, including a combined TAVR device. It's really a fast-moving field, and I'm thrilled to be part of this. I was given the question when to stent type B aortic dissection. Was it type B? Yeah, type B. And I scratched my head whether I should address when in terms of what particular group with what cofactors or comorbidities or what risks, or when in terms of a time domain question. I'm trying to look at both now in the next few minutes. This is a statement that I was invited to write 8 years ago. Should we stratify patients with type B dissection for endovascular treatment? Of course we should. I think there's a genuine thought that not everybody is suitable for that, and there's alternatives. There's certain groups that don't deserve it because they're doing well anyway, or they're too old to benefit from it. So stratification is, I think, an overarching concept for treating endovascular, for using endovascular concept. And this was on the heels of this publication in JACC 8 years ago in China, a big group of patients that underwent unselected endovascular treatment. And I was in a position to, my voice was basically for stratification. The means of stratification is something we are still discussing and partially here. Who is a patient suitable for an endovascular approach to benefit from it, not only to do it, but to benefit for the patient for it. And this ends up in the discussion earlier today. What are high-risk features? Do we accept high-risk features as part of future complications, or do we just ignore them because they're all uncomplicated anyway and may have some high-risk features with or without any meaning? This is a statement, basically a table from the recent European guidelines published earlier this year. They basically divide their patients in clearly complicated ones with the known features of complications, which is impending rupture or malperfusion, clinical malperfusion, or high risk. They gave them the appropriate classification, 1 and 2A for endovascular treatment. And interesting to show that the high risk features here are listed again in so-called morphological criteria. I don't need to read them to you. And clinical criteria, the before discussed features that Santi published some 15 years ago, I think, or 14 years ago, persistent pain and uncontrollable hypertension based on observational evidence in IRAD. Here's a case of a type B dissection which undebated complications of malperfusion, as you can see on the angiogram. This patient definitely benefits from an endovascular true lumen scaffolding approach. In this case, we put in a TEVAR or 2 TEVAR devices extended by an open stent configuration down to almost the bifurcation in order to alleviate malperfusion, to basically set the stage for remodeling and not compromising any side branches. So this is a very well-established concept in acute complicated type B dissection, including a petticoat extension to the distal part of the aorta. Back to the guidelines, recently published, the European guidelines basically found a solution to this conundrum about uncomplicated and complicated dissection by basically omitting the uncomplicated and replacing them by patients with or without high-risk features. So we have complicated aortic dissection on the right-hand side, malperfusion, I mentioned that, clear-cut avenue down to either surgical attention with the, in case the arch and the ascending aorta is already involved with some reasonable dilation over 4.5 centimeters, or an endovascular approach to not only alleviate malperfusion, but actually to treat the patient. And then it's to us as the attending physicians and surgeons to identify high-risk features in a patient. Not just leave it to anybody else to manage the patient medically. If you identify clear-cut features of high risk or several features of high risk, I think the patient will, based on observational evidence, benefit from an endovascular approach. That solves part of the solution, part of the problem of differentiating non-complicated or uncomplicated from high-risk features. Here's a pictorial case of how we treat these patients in our center. It's a patient considered to be uncomplicated with no malperfusion. Optimal medical treatment, of course, as a first leg in the treatment concept, and which means blood pressure management, essentially. After 10 days, we would scaffold the proximal part. We occlude, in this case, the left subclavian and bypass it before. Nowadays, we have single-branched devices that can help us to avoid this operation. Essentially, it's the same approach, distal extension in order to promote distal thrombosis of the false lumen, better remodeling. And then on the way out, we identified a re-entry tear in the left common iliac artery, which was eventually patched with a small stent graft again to isolate the false lumen from pressure and flow. This would be the recommended approach in a case. Today, this is just an example of the use of a unibody single branch device to avoid the bypass in the left neck, which minimizes complications, hopefully, but data are still early. What can be done and achieved was recently published in this series from China, which really is again, the use of the single-branched unibody device with an automated or with an attached petticoat or distal open stent device, as you can see in the upper right corner. This unibody device, it comes in one piece, allows basically to implement the benefits of distal scaffolding with a petticoat or open stent configuration. And obviously this observation from a single center in Beijing is quite intriguing. If you don't do that, of course, aneurysmal expansion of the distal part or the dissected part has to be expected under medical management alone without the option to remodel, to actively remodel. So my biased opinion in some sense is that there were errors in medicine, in the history of medicine. I think medical management alone without giving the patient the option, of course, needs to be supported by randomized data, I agree with that, is aneurysmal degeneration long term, which then, of course, affords more complex operations, mostly open operations or complex endovascular procedures to take care of that. Remodeling over 2 years obviously has a benefit for a late outcome. However, this is randomized but not powered strong enough to show the evidence and prove the evidence. The power is too low. That's why we need the randomized trials we discussed earlier today. Is there a benefit from proximal false lumen thrombosis induced by an endovascular scaffold? I think there is. This is one study that shows that proximal false lumen thrombosis is actually a prerequisite for remodeling and to avoid aneurysmal degeneration long term. This is one of many studies. I just show this because of the pictures. There is another example here from Germano Melissano, who put this together a couple of years ago and showed that a volumetric analysis actually proves that with remodeling you have a stable aorta and you can expect a longer outcome, better outcome. False lumen is important. False lumen thrombosis is important, and Firas also had an opinion on this. Is false lumen thrombosis the thing? Should it be? I think there's no remodeling without false lumen thrombosis, as shown in this pictorial example, just published a month ago. This is a long-term, 14 or 15 years after the impact, case of remodeling and scaffolding with a simple stent graft in the proximal descending thoracic aorta, inducing false lumen thrombosis with long-term remodeling, and of course proving the point in this nice pictorial example. We discussed the various time segmentation, or the time from symptom onset, and categorized in a very pragmatic way, again based on IRAD insights and Kim's guidance, separating acute from subacute and chronic. This has impact on our studies and our generated evidence from observations in IRAD and out of IRAD by independent groups. The acute phase was determined as 14 days from impact, and then the subacute 2 weeks until 3 months, and anything beyond that is turned chronic. It is really helpful to you and to be used in these observational studies. And here we come to the first ever published observation on the best timing for an endovascular approach. And this is retrospective analysis from the Virtue study using Medtronic endovascular devices only. And they looked at the outcome in terms of false lumen thrombosis when treated in the acute phase, subacute, and chronic phase. And as you can see here on this Kaplan-Meier format, the subacute phase and the acute phase deliver the same kind of results in terms of remodeling, whereas the chronic phase chosen to treat a patient with dissection doesn't result in similar outcomes in terms of remodeling. So the take-home message would be the window of plasticity to ensure false lumen thrombosis and remodeling is open until 3 months. There's multiple other studies, and this is one of many, to show that the acute and subacute cases with endovascular approach have some similarity and some differences. This is VQI data. There's no impact on mortality whether you treat the patient in the acute or subacute phase. However, there's significantly lower need for reintervention if you elect to treat the patient beyond 2 weeks. I think it's quite compelling. And again, comparison on the same set of data, twice as many reintervention needed when primary TIVA was performed in the subacute, a late phase as compared to the subacute and acute phase. This is a meta-analysis called Prospero, based on all the published evidence so far, and it shows on this forest plot a trend towards a benefit in terms of less complication 30 days after TIVA in uncomplicated type B dissection in relation to the timing. And again, the timing beyond 14 days has less complication as compared to the early phase. In terms of 30-day mortality, the same analysis here quotes, again, an edge for patients treated in the subacute phase as compared to the acute phase in patients termed uncomplicated type B dissection. Even a more granular analysis in this independent publication 2022 favors the subacute phase to be selected for treatment. Look at the figures there. With the 30-day survival was 91% if you treated the patient between impact and 48 hours, and compared to a later time beyond 7 days or beyond 15 days, the survival figures were higher at 96 and 97% essentially. So avoiding the early phase, the hyperacute and acute phase, is probably in the benefit of the patient. Same is true for 1 year survival. The same set of data shows the elective repair has a longer elective repair between 15 days and 90 days post-impact, has a better outcome, 92.7% as compared to the early intervention with 80%. Those patients are not similar, of course. This is not a randomized trial, but it shows that if you can avoid the early phase, you benefit the patient. Another study looking at outcomes of TIVA stratified by chronicity shows again in a similar display the best outcomes with TIVA are achieved in the subacute up to chronic phase in patients with type B dissection. Again, highlighting the fact that to avoid the initial phase, the early phase, is obviously helpful. Independent, again, acute versus subacute phase with 5-year outcome. In this study, favors the subacute phase as compared to the acute phase, with less early mortality and less early complications in the subacute phase. There is a lot of talk recently about the risk and the decreasing risk of retrograde type A dissection in the context of elective stenting. And this commentary here basically came to the conclusion that retrograde type A dissection as a result of TIVA is more likely in the hyperacute and acute phase. However, we all, with time over the last 15, 20 years, learned that there is some no-goes in the context of stent placement, such as oversizing, ballooning, use of bare springs in the proximal end, and of course learning in intramural hematoma is something to avoid also this particular dangerous complication. Another meta-analysis highlighting the same observation that between 2 weeks and 90 days post-impact is the window of plasticity and should be used for inducing remodeling with a lower risk of proximal complication. Even IRAT had observational evidence to show that endovascular treatment can reduce the in-hospital death as well as the in-hospital deaths from endovascular treatment in type B dissection. This is an upcoming set of data. Let me just conclude. If the patient is not given the opportunity for scaffolding, there is a risk of 60% of distal aneurysmal degeneration over time. This is, again, a recent publication from Japan looking at national data. In Japan, they have a tradition of following their patients. They're CTing, they're imaging them very often, and they can generate this kind of observational long-term outcome data. You can skip this. My final take-home message summarizes that emergency cases of type B dissection with impending rupture or clinical malperfusion benefit in general from endovascular intervention in the acute phase if needed for complications. Cases classified with or without high-risk features should be deferred to endovascular procedures if you elect an endovascular procedure to the subacute phase beyond 10 or 14 days, but within 90 days, minimizing the risk for retrograde dissection, but still benefiting from the open window of plasticity and good potential for remodeling. Endovascular scaffolding at any stage sets a stage for remodeling and reduces the risk of late aneurysmal degeneration, and RCTs to prove those points regarding timing are unlikely to happen, but further analysis of ongoing registries may shed light into this issue. Thank you very much.